Our first speaker today will be Dr. Kevin Keck. Dr. Keck is the Chief Medical Officer for SCIO Health Analytics with over 25 years of experience. At SCIO, he leads our clinical analytics development team, and his responsibilities include assessing leakage and the impact of quality and cost in provider analytics, guiding the use of prescriptive analytics to measure the impact of therapeutic drug classes based on member risk levels, and enhancing SCIO's behavior economics model. Prior to joining SCIO, Kevin worked as a palliative care physician at the Permanente Medical Group, and as CMO of the Providence Health Plan, he led the effort to create value-based benefit design. Dr. Keck also served as the Chief of Medicine at Kaiser Permanente. Our second speaker today will be Teresa, or T. Rucker. T is an RN with a master's degree in nursing. She has a diverse background in healthcare, including healthcare technology solution support, care management, population health and analytics, education, managed care, medical compliance, and network management. Prior to joining SCIO, T spent the last 13 years at McKesson. In her role as a product or solution consultant, she provided support on software solutions for population health and analytics, care management, and decision support criteria. Prior to that role, she was an education specialist helping clients gain optimal value from licensed healthcare software. Her background includes working with clients in various areas of the healthcare spectrum, including health plans, health systems, medical groups, and providers. To make sure we have achieved our learning objectives, we structured today's presentation to start with Dr. Keck providing a brief overview of some key challenges facing the U.S. healthcare system and how analytics can help bridge this gap. Dr. Keck will also speak from his experience about how providers are changing the way they think about population health and what options they have available to them to succeed in the era of value-based care. T will then join the discussion to give us a deeper dive on how organizations can use an impactability model to improve population health while maximizing their return on investment. And we'll conclude the content portion of today's webinar by pulling back to show you how an impactability analysis fits within the breadth of SCIO's analytics capabilities. And with that, I'll step aside and turn it over to Kevin and T. Dr. Keck?
Thank you, Sean. I'm going to talk about challenges facing the U.S. healthcare system. The quality and cost picture in our system is not what we want. So I'll talk about the direction we're heading. In looking at a population, there's 5 main areas to manage, if you will, and these 5 buckets are on this slide, and they describe the large majority, about 3/4 of the healthcare spend is in these buckets. And we talked about surgical preference-sensitive treatments at our last seminar. Today we're going to be focusing on medical inpatient as that drives healthcare spend. And the other areas are imaging, pharmacy, and emergency department. I'm going to show you the pie chart of healthcare spend, and you can see going around Medicare or commercial that the facility charges, which it comprise surgical inpatient, medical inpatient, ED, ambulatory surgery are a large portion of healthcare costs. This is from a health plan in Pacific Northwest. Now, there is a shift to value-based payment, and Sylvia Burwell has announced that. 90% of payers and 80+% of hospitals now offer a mix of fee-for-service and other reimbursement models. And by 2020, it's anticipated that 2/3 of payments will be based on complex reimbursement models with underlying value measures. And Sylvia Burwell has said that 30% of Medicare payments will be tied to alternative payment models by 2016 and 50% of payments by the end of 2018. Now, in looking at how to approach these reimbursement models, I'll go through this slide clockwise. That the IHI, Institute for Healthcare Improvement, AAA, is looking at improving population health, looking at improving per capita cost, and looking at improving experience of care. Given that, look at the increasing rates of chronic conditions. There is an increasing burden of suffering, if you will. And this shows that in Medicare population, the rising rates of diabetes, rheumatoid arthritis, osteoarthritis, depression, chronic kidney disease, and these are rising substantially. Now, the challenge, if one is going to manage a population, is devising systems of care. Regular care in the exam room is not going to get to the AAA because of this simple fact that the physician or the practitioner sees the patient on average 40 minutes a year, and it's virtually impossible to educate, motivate, and empower a patient to understand and control their illness with that little time frame. So the challenge is how, as a risk-taking organization, an ACO, for example, or a hospital system, for example, how do I do systems of care to mitigate these cost trends? And the other way to say it is, how do I do this so that I improve quality? Sorry, this is slow. Okay, so this shows the increasingly complex patient populations with medical chronic conditions. Again, going clockwise, the upper left graph shows the percentage of seniors who are obese by age group. It's going up. The next chart shows the spending costs based on number of chronic conditions, and then as you can see, the spending goes up at at least linear rate, maybe exponential, as number of conditions increase. And then the bottom chart shows percentage of seniors with 2 or more chronic conditions. And you can see that that is going up, comparing 1999 to 10 years later. The key chronic conditions that CMS is focusing on, if you take a look, it comes into these conditions. And in population management, we call these the big 5, but there are many other chronic conditions. And CMS is starting at a basic level that everybody can agree on. And these chronic conditions are chronic obstructive pulmonary disease, asthma, coronary artery disease, heart failure, diabetes. Now, there will be other conditions, and other conditions which are chronic, which cause burden of suffering that we could do a better job in, would be things like multiple sclerosis, or amyotrophic lateral sclerosis, or high-risk pregnancy, or inflammatory bowel disease. So I would predict that those are coming because they will have a bearing on cost. Now, the paradigm shift in caring for a population is demonstrated in this slide, that we are changing from fee for service, that is fee for seeing the patient doing the service, to fee for value. There needs to be a measured outcome. We're changing from sick care to well care. In other words, a patient that has prediabetes, we want to identify and change behavior so that they do not become a diabetic and stay well. The current system takes care of the patient when they're sick, and that is when they're in the hospital or in the ED. And what we need to do is care for the patient in a continuum so that when the disease is identified, there can be an intervention. When the patient sees a doctor, that's coordinated. When they're in the hospital, it's coordinated. And lastly, our episodes of care are fragmented. You know, think of the diabetic seeing the orthopedic surgeon for a total hip repair, and they have a problem with their foot, and they have to see the podiatrist. So that care needs to be coordinated so that the patient can do well. The bridge between these systems or paradigms, the bridge is analytics. Now, in managing a population, and I've done this, and I have managed a population in Oregon where the costs were poorly controlled, and by using these 9 levers, we were able to improve quality. Now, that flowed to the bottom line. The state of Oregon asked us what we were doing. They thought we were withholding care, and we told them, no, we're doing these things to improve quality. And then the state of Oregon gave the school teacher book of business to my health plan, and the next year the state employee book of business to our health plan. But if you think about managing a population, these are the 9 things that you can do, and they are, I'll touch on them, that physician feedback, giving the physician data. There can be an incentive. There may not be an incentive. The incentive could be as little as $1,000. It could be as much as 30% of W-2 income. All of those have worked, and the more incentive, the better. Patient education, letting the patient understand their disease so they're empowered and know they can do something about it. An incentive can be gamification, and they can play a game on their smartphone and get points. That works. Inpatient management, making sure the patient gets to the hospital, stay appropriately, and critical with this is articulating the patient with outpatient care, very dangerous time in medicine. There's outreach for case and condition management. If the patient is high risk and has diabetes and has gaps in care, then some kind of an outreach is appropriate to close that gap in care. Prior authorization is making sure that the requested service meets evidence-based guidelines. You know, think of pharmacy management in third tier. This is a prior authorization example. Claims audit, all risk-taking entities should do claims audit because 8% of insurance claims are flawed. Most of those are in healthcare. Unit cost network selection, what is the conversion factor? What do you pay for a DRG unit? Who is in the network and who is contracted? Capitation is pushing the risk to the provider, and if the provider has a substantial portion of the business of their specialty, such as cardiology, then there can be arrangement where the providers take direct risk. And lastly, benefit design, and this is where some behavioral economics can come in, that patient has better benefits for chronic medical conditions. So if you will, these are the levers that can be applied. We've shown that the lighter blue are for the risk takers that can define the benefit. The blue are those that are taking risk. This is an article recently about nurse-managed protocols. This is one way to manage chronic conditions. The article says that nurse-managed protocols may have benefit. In my experience, in my operation, it worked with measured outcomes. I know that the track record is checkerboard, but when done correctly, with correct patient selection, correct nurse intervention, there will be a measured outcome of improved quality. And the strategy with nurse managers is to have the nurse managers cross-train, in other words, make them Swiss Army knives, so they can manage more than one chronic condition in their expertise, because patients tend to have more than one chronic condition. Also, what the nurse managers do is educate the member about their illness, motivate them to do something about it, teach them that they can do something about it, and then empower them to take care of themselves. So with that, I'd like to turn the program over to Teresa, who is going to discuss with you the Impactability Model, which is the analytics necessary so that one can identify and impact members who need an intervention.
Thanks, Dr. Keck. Hi, everybody. This is T. Rugert. So we're going to be going over the SCIO's Impactability Model. And with SCIO's Impactability Model, I just wanted to kind of start, the goal in healthcare analytics is to gain knowledge and insight into actionable information to help increase quality and reduce costs. And so as we do that, we'll begin to look at the actual Impactability Model. So talking a little bit about the Impactability Model, really it's a set of models that helps me prioritize, not just who's at high risk in my population, but where and who can I actually have a potential for the biggest impact, reducing, for example, inpatient and ED costs. And we do that by looking at the patients with 10 chronic conditions and then helping to quantify the care gap prioritization for the members, looking at possible cost savings associated with the gap closure related specifically to the probability of reduction in avoidable inpatient and ED. The Impactability Model then provides a member list with prioritization of the care gaps by member. And so again, it looks at the 10 conditions. It includes, as Dr. Keck talked about, those 5 that CMS are focusing on. Data sources for this model, claims data, medical, pharmacy, eligibility data, lab data, and the refresh on this can be weekly, or monthly, or quarterly. So just kind of a high level on that Impactability Model itself. As we move forward, let's talk a little bit about the model methodology. And so when we're talking about the model methodology, what we're looking at here is that how the model is set up. And the model uses 1 year of commercial data, and it's a logistical regression model is used basically to quantify that association between care gaps and inpatient and ED risk. The final impactability score is given, and that looks at the probability and reduction of those inpatient and ED stays after closing those care gaps. Looks at different variables. We have the independent variables, the demographics, the risk score, condition indicators, the care gaps, and then the dependent variables. And again, we're going to be looking at the indicator for avoidable inpatient and ED stays. So as we move forward, let's talk a little bit about the model validation. And so when we're looking at model validation, we're looking at the area under the ROC curve, and what that is the receiver operating characteristics. A logistical regression model is evaluated or can be evaluated in several ways, and one of which is this ROC curve, again, the receiver operating characteristics. So if you look at the graph here, on the left-hand side, going up, you see true positives. Across the bottom, you're seeing false positives. And so with this, what you want to be able to see is that high curve going up. You want to see that bigger area underneath the curve, because the bigger the area underneath the curve, the more true positives you have, the better the model. And so with our impactability model, we have for the inpatient ED a 0.93 and a 0.76. Anything over a 0.70 is considered good. So it's got a really good ROC curve here. Let's talk a little bit more, move a little bit more about into the actual impactability and intervention optimization by conditions. As I talked about, at healthcare analytics, again, enabling change through knowledge with actionable insight. So how do I gain that knowledge? How do I learn about which conditions, which members, which patients I can act on to accomplish positive change? This right here, this is an example of using our impactability and intervention optimization model. I affectionately call this the bubble chart. But basically, this chart here shows me where I can identify my costs on conditions and which conditions have the highest impactability, where I can have the biggest impact. And as we move towards the left, with the least complex interventions. We're going to talk about this particular chart or this dashboard in a little bit more detail, but I just wanted to stop here and kind of present this so that you can see what impactability is all about, what the advantage is going to give you to be able to identify those conditions, those costs, where you can have the biggest impact. And again, look at the least complex interventions. Gives you a place to start. So let's move forward and talk a little bit about some of the information that's provided. What you're looking at here is the population overview dashboard. And really what's nice about this is that if we look here, it doesn't just show me which of my patients or members are at high financial risk for cost in the future. That's important. But it also shows me which of my patients or members have high impactability. You look up on the right-hand corner up there, and it's broken down by segments. It's looking at my count and cost, the percentage of my members that are in those different segment buckets. The first one is high impact, high risk. Small number of patients contributing to the high amount of the cost. In fact, if you look at it saying, my high risk, high impactability segment accounts for just a little over 10% of my population, but over 33% of my costs. So being able to understand which patients or members fall into that high impactability bucket, along with looking at their risk, is what the 4 squares on the left are showing me. So I can look into that and be able to then click on that and get a drill down of who those patients are. Again, let's focus on the ones that we can actually have impact with. As we move forward, let's talk about where we would go from there. So say I clicked on the list of members that maybe have not just high risk, but have high impactability, for example. Then I get to that level where I can look in more detail. And this is important because let's say I'm an organization and we have a big problem in ED visits. And I've been asked maybe by my leadership to help address that ED utilization. And so the impactability can actually translate into a potential reduction in ED visits. So I look at that initial chart we were looking at, and I focus on those high impactability folks. And then what we're doing now is we're drilling down to the member and patient level. So this example is showing us our potential ED reduction. We also have it for inpatient reduction. And we can calculate the savings on that. We estimate the reduction for ED visits. We look at that in two ways, or with two scenarios. When we look at it for those conditions, care gaps open and the probability for that person to have an ED based upon looking at our past database, and those with care gaps close for ED for that patient. And we take the difference, and that gives us the avoidable ED. Then we convert the avoidable number of ED, multiply that avoidable number of ED by the average cost, and we can actually even quantify that savings. So just looking at the slide here as an example, you take a look at that member. We've drilled down to that high-risk bucket, maybe looking at that member. Let's say that's T up there. And then I have if you go across to the right, a probability of ED admission of 93%. Well, if we close the gaps in care that are associated with that person's condition, the probability of ED goes down to 22%. That's a 71% difference. That person, if that's me, T, is going to have a really high impactability score. There's a lot we have the opportunity to be able to impact there. Not only looking at that, but as we look at the bottom table here, it really shows me for a patient how to prioritize gaps. So we quantify the ED and inpatient savings, as we said, for each care gap, and then compare them and prioritize the top 3 to 5. And it can be updated with a monthly refresh. So again, that top person there, we've got their risk score, their impactability score, which to me is really important, and then those top gaps to be able to work on with that patient or member. When we're looking at this, we move forward, we're looking at condition prevalence. And we're looking at this because we can use the impactability model to look for opportunities in different ways to help me see what types of conditions and programs actually I may want to start with. So for example, this one looks at volume. If we look over on the far right-hand column at total, it's letting me see the volume of my patients that have hypertension, diabetes, depression, asthma. Those are the top 4 up there. But do I have the same opportunity to have impactability with all those different conditions? Where may I want to start my program? Well, if I look over in high impactability, it's actually the top 2 conditions where I could have the most impactability, hypertension and diabetes. Again, the whole idea is to gain insight into where you can start actionable information by using the model. Another way we can look at this as we move forward is the cost distribution by condition and segment. And really it looks at it from a financial perspective. So it may help me, for example, looking at my high impact, prioritize which conditions I want to start with. So as I look at this slide and I look to the far left, I've got my high impactability column, and I can see the blue and green there, which represents, my hypertension, diabetic patients. And we've probably got about a 30% of cost attributed to those. But then let's say, all right, now we're going to start with our moderate impactability folks. We're working on our high impactability folks. If I go to my moderate impactability, well, where do I start? I've got multiple conditions here. Well, hypertension is accounting for 40% of my cost there, more than any other condition. So again, helping to give you insight to drive you in the right direction, to help you prioritize where to start programs and where you want to spend your energies, a different way of looking at that. And let's move forward, and we're going to go back to our affectionately called bubble chart. And this is looking at my intervention optimization. And so it looks at the conditions, the costs for those conditions, at the impactability and the complexity of the intervention. So if you look up at the top, as you move towards the top, those are the conditions that are easier to impact, have that higher impactability score. If you move towards the left, those are the conditions that have the least complex interventions. So for example, if you look up on the top there, we've got on the top left, hypertension, CAD, high impact, least complex interventions. Gives me that place to start. And just to give you a little more information on this, to determine the complexity of interventions, we first identify the list of interventions that may be applicable to each condition based on literature and practice. Then, based on the intervention list, we further assess the availability, and that might be related to the benefit design and the cost effectiveness of the interventions and the risk severity of the specific condition. And then we come up with a composite score, that's that complexity score, to determine which intervention is the optimal intervention for that specific condition. The impactability score reflects the patient's compliance with quality measures for their conditions. That may include behavior or knowledge of the gaps. As we move forward, what we're going to look at is the intervention optimization a little bit differently. So we looked a few minutes ago at that individual and how we can look at that individual and their impactability score and what the potential savings was. Let's look at intervention optimization now for a specific condition. And so we're looking at it here for hypertension. So when we look at the top left, we see that kind of bubble chart specific for this. I'm right here looking at the impact and the complexity of interventions for this condition. We're looking at an aggregate level now. On the top right, what you see is optimal interventions for the condition. So we're talking about the interventions for the organization. And so that might be, depending on the organization, things like benefit design, which might have to do with, you know, what type of incentives can we include? What can we do with copay? They might be doing with things like number 2, dealing with the use of particular providers, you know, better performance. How do we use incentives to drive to high performance providers? Or the clinical possibilities, you know, and being able to educate patients in certain areas. And as we look towards the middle there, that blue bar going across, that's our service bar. And I think that's really important because we looked at the individual level in gaps, and here we're looking gaps and services at an aggregate level for the condition. In other words, the top ranking services related to quality measure compliance. Look on the third column there. So those 1, 2, 3, 4, 5 of them listed there. Ranking, and that is based on the potential cost savings for this hypertensive population. So those are the top services. We look at the graph on the bottom, and that's giving a graphical or visual view on that. So, for example, on our service bar, what do we have? And our hypertensives as the top ranking service there. When you look over on the right-hand side of the bottom graph, and we see that our benchmark for that is 63%. Our overall population may be meeting that at only 48%. But our high impactability folks today are only at 47%. Okay, so it shows me that's the area of opportunity that I have looking at this condition at an aggregate level on what services we may begin to want to look at. So which interventions are optimal to begin with or start with. One of the things as we move forward is looking at compliance summary, and that has to do with gaps closed. And so to think about it, if I'm managing these patients and I've identified them now, I'm going to initiate a program, but I want to know about the impact that it's having on closing gaps. So this analytic dashboard is all about the impact of closing gaps related to potential savings. So if you look over here on the right-hand side, it says top 10 gaps closed and top 10 gaps open, and then it's got some numbers next to it. That could be looking at actual numbers, gaps closed and gaps still open. That a number could also be potential savings, so that's another way that we can present it. So the potential savings that we have for those gaps that are closed, and the potential savings still as an opportunity for those gaps that are open. If you look on the left-hand side, then we begin to look at compliance care gap information. And so on the left, when we look at that section in the middle, the total savings. And so each bar here represents the monthly savings due to the gap closure. So we're looking at the monthly savings here in September. We've got a lot of savings listed there. And then the bar underneath that is the total savings per gap. So we want to make sure we're looking at the gaps that actually have our high impact gaps. October, we dealt with and closed a lot of the high impact gaps, and actually being able to drill down and see which of those gaps that were specific for that were high impact gaps. The impactability, we'll move forward here. In the impactability model, one of the interventions I briefly talked about was benefit design. And that's another model that SCIO has available, and that's related to our incentive optimization model. So once you've identified your, maybe your consumer segments, your prescriptive network analytics like incentive optimization, helps an organization to design member incentive packages so that they are at the correct level for the right condition and services and for the maximum benefit and savings for your organization. So, for example, if a patient needs to get a health check or a diabetes exam, how do we incentivize them to do that? Do we do cost sharing reduction? Do we offer a financial incentive to help you be able to figure out for your organization the highlighted options above give you the best PMPM? So let's look at let's take a look at the graph right there on the bottom first. When we're looking at that, on the bottom, on the x-axis, we have the financial incentive. And on the left is the savings PMPM. And this is important because at some point, your savings tops off. No matter what incentive I offer, the graph shows me where it peaks, which corresponds to the highlighted best options in the top graph. So no matter what cost savings I offer and what incentive, there's a peak. So if we look on the top, and if we're saying across the top cost sharing reduction, if there's no cost sharing reduction, then 250 is the incentive where we're going to get the best PMPM return or savings. If I'm going to offer a 25% cost sharing reduction, then $200 will give me that highest or best PMPM savings. So incentive optimization is about, where when we're looking at this that we have the best opportunity, and how do we put those two together to get the best results and the best savings from that. When we look at this also, we look at incentive optimization, and it helps prioritization of conditions and services. So it tells me by changing my benefit design, the savings potential for conditions. It shows me the top 3 out of 25 gaps that can have the potential impact on. So for diabetes, there's my savings potential, and these are the top 3 that I have the biggest potential for savings on. Now, I'm going to stop for a minute here. We have been, looking at impactability, and impactability is a part of our health analytics solution. SCIO, just so you know, means to know or to understand, and so the healthcare analytics solution is designed to help you with that. Our mission statement reflects what SCIO believes, which is, there is urgency in driving positive change in healthcare, and that knowledge enables this change. We do this by helping organizations think differently, by gaining knowledge through actionable insights to complicated problems simply and effectively and efficiently. And so our mission is to give you that insight so that you can make those judgments, those calls based on informed insight and information. So as I move forward, I thought I'd just give you a high-level overview on the analytics solutions. I know we specifically looked at impactability. Now we're just going to kind of take a step back, a higher-level overview. Our focus, again, is to provide actionable insight across the continuum. You see us here in the middle and all those areas in the continuum around us. We do that by using prescriptive analytics as a focus, and that helps to further collaborate across those different domains and to drive outcomes and impact. The idea is to get data one time and use it many times in those various areas. And so as we move forward, we'll talk a little bit about SCIO Health Analytic domains. I affectionately call this my circle slide. And really, when you look at it, on the left is population health analytics, and then on the right is network performance analytics. On the bottom is stakeholder outreach, and then we do have solutions also for payment optimization. So let's talk about those 3 segments of this domains. And so when we're talking about population health section of it, we're talking about how do I ID, how do I identify and understand my population? Who are they? Who's at risk? What are my opportunities regarding utilization and cost? What about quality compliance? Understanding that population. And then once you've identified and worked with that population, going back and analyzing the outcomes or the impact of your interventions and programs. That's the population health analytics. On the right, network performance analytics is designed to help you understand your network and evaluate your groups and your providers and your costs. Look at your network opportunities, standardizing care around top performers. And that bottom domain of stakeholder outreach is really all those folks that we've identified, those identified opportunities to drive appropriate outreach through workflow, through communications, efficiently utilize resources to drive the desired outcomes. what I wanted to talk to you a little bit about is the solution architecture. There's a lot on the screen, but just to give you a high-level overview, if we move from left to right on this. SCIO solution architecture, we have a file-based transfer. We look at claims, financial data, activity data, and all that data on the left then comes in and it's categorized. And now we're kind of in the middle with that data transformation. And that data is categorized in different areas and applied to the population for a time period, really a member profile, a cohort of members for a time period, all the way down to the individual member level. So the data comes in, it's categorized, it's applied to the population, and that is what is then used in those analytics on the right in that circle. That information can be looked at in various ways. There's a robust suite of tools here. What underlines all this is the platform, and that platform not only brings in that data, categorizes it, and helps run those reports, but that's where someone might go for ad hoc reports. So it has the flexibility for that. But there are also dashboards. These dashboards are designed to get the right information to the right person at a level that makes sense for them to be able to then utilize that information, whether it's at an executive level or at a director level, or even in the program manager level, to be able to get the right information in the right dashboards. And then, as I mentioned, there is a workflow tool to be able to utilize that information to help drive to the appropriate level of intervention and workflow. So as we move forward, let's talk a little bit about the analytics solution. As the environment is moving towards, or the healthcare changes move towards value-based reimbursement, organizations are undergoing a lot of change, and they may be at different points along this journey at this point. And so SCIO has a solution that can fit wherever someone is along this journey. So we'll look at this kind of in 3 layers. We'll look at it from bottom to top. At the bottom, we might have organizations that are just beginning along this path, and they're looking to transform clinical and financial data at this point into meaningful insight, looking at their population and network, identifying and stratifying their member, measuring network quality or network performance. As we move up towards that middle layer, we deal with others who might be ready now for analysis to drive efficient and effective care using actionable insights. So determining actionable care gaps, measuring the success of our population and network by tracking outcomes, for example, or network performance. And still, other organizations, they're up at that top level. They're more, they've gone to a farther distance at this point in the journey, and they need tools to be able to assist them in looking to optimize care and operations and really looking for recommended interventions to understand specific interventions or make more informed decisions about their network and their packages and programs. The key is that SCIO is here and provides analytic solutions at all those various levels, no matter where you are on that journey, moving towards value-based reimbursement. I thought we would take just a quick look, a high-level look at some of those areas. Remember that circle slide, the top left talked about population health analytics. This is a home screen from the dashboards on that, and really it focuses on those key areas that we all know we need to understand and look at. Who is my population? Who is at high risk? What diseases have a high prevalence in my organization? What are the costs associated with that? Being able to look at quality of care. Where do we have gaps in care? For which conditions? What is our compliance rate with particular quality measures? And looking at cost and utilization. We look at cost and utilization, we might be looking at the distribution of costs, and is it, what service level is it at, all the way down to what's driving my inpatient or ED, or looking at readmissions and other high cost areas. So I thought I would just pull up, and I know this one is a little bit of an eye chart here, guys, but just to give you an idea of what's underneath all those little bubbles, I pulled a couple into here. So on the top left corner, I might be the executive, and I'm like, first off, where do I start? How do I dive through that haystack and find the needle? Where do I need to focus my energy? What's my trend, and what drove that result? So I may look on the top left as an executive dashboard to be able to look at that and try to understand, is it a particular condition or disease where my costs are going up or down? Is it a particular type of utilization, ED or inpatient? Moving towards the right, there are dashboards that help me understand, as we talked about, risk and impactability. Not only where are my high-risk members, but who are the ones that we can have impact with? Or maybe I saw that I have a growing trend for higher cost in inpatient utilization. Well, where do I start with that? Looking down on the bottom left, being able to look at analysis, a dashboard that lets me see which diagnostic categories and diagnosis are driving my costs going up over quarters. Or where are my quality measure gaps for diabetics? Is it a particular gap that, maybe 80% of my folks aren't having their eye exam? So getting that level of detail of information. Moving forward, we'll also take a look at a model we talked about, I think, in our last webinar, but in case some of you were not on the webinar, I'll just talk about it for a brief minute, is preference-sensitive treatment. And that's a model that looks at preference-sensitive conditions. And so those are conditions where there's really no definitive clinical guidelines. There might be more than one treatment option. And those are preference-sensitive treatments. Those medical care where clinical evidence doesn't clearly support one or just one treatment option. If you look on the bottom there on the left, those 5 conditions, for example, knee osteoarthritis, those are the conditions where we have preference-sensitive treatments. And really the course of treatment depends upon that communication between the member or the patient and their provider and looking at the evidence and what's the best treatment option. So SCIO has a model that lets you know which patients are actually at risk for these preference-sensitive treatments. And so as we look at this, for example, it's not just which ones are at risk, and maybe that first member ID is ME-T, and we're looking specifically at knees here, but where am I in the path of treatment? So there's different phases in treatments for these preference-sensitive conditions. And so somebody might be at the highest severity level up at 3, or they may be down at 1. So letting me know where they are along that path so I know that I have the opportunity to intervene. And maybe I can intervene earlier on and have the opportunity to reduce those costs associated with that preference-sensitive treatment if it's applicable. So looking at me, that first member up there on the top, I may be kind of in the middle of my severity range. It lets me see what my last treatment was. The remaining episode costs all the way up to that treatment, we've got 26 to 80,000 there. But the expected savings, if I can intervene at this point, is almost $50,000. So that's up there with the #1 ranking. So it helps rank those patients with preference-sensitive treatments. Again, identifying folks, giving you insights so that you can act early on and know where to intervene. The other important piece is being able to say, all right, now we've done our programs, we've intervened. What about our outcomes? And we have annual reports and quarterly reports dealing with outcomes, or dashboards dealing with outcomes. When I'm looking at those quarterly, really help me see for my participants in a program, and it has participants and non-participants, am I headed in the right direction? It's kind of a check. Are we heading in the right direction? Are our inpatient stays going down? Are our pharmacy costs going down? I'm checking how we're doing on that program. Annual outcome reports actually are geared towards looking at the impact of the program. And annual dashboards, these are looking at outcomes, whether they be utilization outcomes or clinical outcomes. And what we do is we look at not only the participants in your program, but also the non-participants, and that's really important. The reason that's important is because when you're intervening with a population or cohort, you never just want to compare it to itself. You don't want to do that because of regression to the mean. So, for example, if I have a really sick population, they may be going to the hospital a lot in the beginning of 1 year, a lot of utilization, a lot of costs, and just because of that regression, I mean, their costs are going to naturally go down a little bit after that. So I can't just look at that and say, oh, we've had impact. I need to compare that baseline to my measurement period, not only for my participants, but for my non-participants, and then look at the difference between the two. We call it the difference of differences, and then that allows me to see the actual impact of my program. So that was a very high-level overview of the additional SCIO Health analytics in addition to the impactability. And with that, Sean, I think I'm going to turn it back over to you.
Awesome. Well, thank you, T, for that, and Dr. Keck as well. But before that, as you mentioned, we are in our question and answer session. So as a reminder for folks, if you could please, on the right of your screen, there should be a questions module. If you have any questions about what you saw today, please just type them in there, and then they'll all receive them and be able to articulate them to our presenters today. During the course, we did get a question around sharing of the slides in the presentation, and that's actually a question that I can answer, and we will be sharing a recording of this presentation for anyone who registered and attended the webinar. It will also be posted on our website a few days after today, so probably by early next week. But we did get a question that came in, and I think this is referring to that bubble chart, the intervention optimization, I believe, and around considering the complexity of the interventions, and maybe just go in a little bit more detail on how that is determined, if it could be standardized to a specific organization, and if cost is considered when we're determining how complex an intervention is.
I'm sure it's looked at.
Yeah.
Go ahead, Dr. Keck.
Go ahead. Well, I'll just say that the interventions on that bubble chart are the 9 interventions that are articulated in a few slides before. So some of those don't cost very much money, such as a benefit design. You program the computer and then sell the product, and that's the cost. The more complex the medical conditions, such as end-stage renal disease or COPD, the intervention is more costly because to get an outcome, you need a licensed person at some point, or for all of the interventions. So each of these levers has a cost, and that bubble chart was derived from looking at the literature as how to best impact that chronic condition.
Great, thank you. And T, was there anything that you were wanting to add to that?
And I was just going to just add on to it, the process for identifying those. So again, looking at the literature and practices out there, and based upon that list, being able to then look at the availability of those interventions, benefit design, as Dr. Keck, I think, alluded to, and looking at the cost of those, and then based upon those, then giving it that complexity score.
Awesome, thank you. Well, we got a couple questions on, I think, that lever slide, and I think this one's directed to you, Kevin. If you could describe the kind of member outreach that you're talking about in the levers, and then there's another one around the idea of gamification, if you've seen examples where that has worked well.
Sure. Okay. The member outreach is a complementary system to what goes on in the physician's office. So it works hand in hand with the physician's office. The outreach is done in a variety of ways. We found that two-thirds of Medicaid members in New Mexico have a smartphone. We found that very interesting. And when your member has a smartphone, then that gives you 2 methods of intervention, or 3 or more with a smartphone. There can be push notifications, and these can be done on a daily basis, so that the member gets a reminder as the patient chooses of how to be educated and motivated to take care of the illness. Another methodology, of course, is email on the phone, and by segmenting the population, you can tell who wants which form of communication. Everybody has a telephone of some description, so an outreach by a live person is another methodology. That live person can be a nurse or can have a cheaper license. it can be an LVN, it can be a medical assistant, it can be a dietitian. Gamification is the methodology of getting the patient interested in playing a game on their phone for which they get a reward. And I'll just say an example with diabetes in a Medicaid population using point rewards, which the member could then turn in and get prizes. Think of blue chip stamp stack when I was a boy. But getting points, which can be turned in for a reward, got a measurable outcome in diabetes care. So having the patient play a game, and the smartphones all have games, is another tool that can be done to educate the patient, motivate, get them to understand that they can impact their illness, and that get them to impact their illness.
Right, and we just received in a question here, and I think it's in reference to the impactability section, so I don't know if it's directed to you or maybe Dr. Keck if you want to chime in, but asking around how the acceptance of these findings, if they've been accepted into practice, and then as a secondary question, how long I think ROI might take to translate from the findings of the impactability model.
Let me tackle it. I'll answer the second question first. That if you want to do an intervention and measure an outcome, it usually takes about a year, and that's a challenge with the quality people and the chief financial officer, because if you start an intervention today that has a cost, you're going to measure your ROI next year. So that's always an issue. As far as acceptance goes, physicians behave the way they are measured. They behave better if they're measured and get a reward, and then they behave really well if they get a reward that looks like 30% of W-2. So if the physician is presented with this patient has a gap in care, it might be on the electronic medical record, they will respond to that. So to manage a population, does require physician leadership too, along with the analytics. But these gaps in care are well accepted as things do, and they're evidence-based medicine. So yes, they're nicely accepted.
Great, thank you. Well, by my watch, that brings us right to the top of the hour here. So I'd like to extend my thanks to the audience for joining us today, as well as to Dr. Keck and Teresa for giving, I think, a great presentation here. And with that, that concludes today's webinar. If you, as a reminder, this session was recorded and will be sent to you in the coming days. And thank you all for joining. Have a great rest of your day.
Thank you.
Thank you. Goodbye, everyone.